cataract, and various refractive surgeries. Dr. Ismail also has surgical experience in corneal transplant and ocular surface reconstruction. He holds multiple prestige degrees and certifications in the field of cataract and refractive surgery, including an MSc in cataract and refractive surgery, a certificate of laser and refractive surgery from the Royal College of Ophthalmologists, and a subspecialty diploma in cataract and refractive surgery by the Fellow of European Board of Ophthalmology. So today, Dr. Ismail will be discussing childhood keratoconus, which is a life-threatening condition which affects many young children and adults in the world. I would just like to remind you all to make sure that you're kept on mute, and if there's any questions, you can post them in the chat box, and then we can talk about them at the end of the session. Thank you.
Thank you very much, Sonal, for that introduction. I've been flattened by that. Thank you very much, Sonal. So basically, good morning, everyone. And essentially, I'll try to make this presentation as practical as possible. And we want to get absolutely to the point, what is childhood keratoconus and why it differs from the adult keratoconus, basically, and highlight some of the challenges and solutions that we have for childhood keratoconus. Now, I can't go to the next slide now for some reason. Yeah, no, that's okay, it's working now. So the objective is really to explain the risk factors for keratoconus in childhood, describe the diagnostic test for patients with keratoconus, outline the treatment option, but more important, which I haven't put that here deliberately, is just to say how and why childhood keratoconus differ from adult keratoconus, basically. And that's really the main gist of today's talk, actually. So first of all, the prevalence of keratoconus worldwide estimated to be 1 in 2,000. So that's 0.05%. However, in UAE children, the prevalence of keratoconus is 54 times higher. So that's significantly higher amount of people in UAE have keratoconus than the worldwide reported prevalence. You can see the reported incidence in UAE is 2.7% in school-aged children. But that's actually not unique to UAE. If you look in Saudi Arabia, it's actually the prevalence is even twice as high, at 4.79% in children aged 1 to 17 years, and 2.4% in an Iranian college student, 4.8% in Egyptian pediatric patient, and 2.4% in India. So you can see the prevalence of keratoconus is significantly higher in Middle East and Asia compared to the reported one, which is mainly the data come from Western world. And that's why so important for all of us to have a very, very high vigilance and to be always vigilant that any patients you could see who has any sort of decreased vision, that it could possibly be keratoconus, because 2.7% means from every 100 patients you see, you should be diagnosing 3 with keratoconus. So that's what it implies, and that's a huge number. Each day in a clinic, we see 30, 40 patients. So literally we should be seeing, even in that, we're talking with a general clinic. Of course, my clinic will be very different to corneal clinic. But in general clinic, you'd expect to see 3 or 3 patients who will come to you, they have keratoconus. And this is our role is to make sure we diagnose that and start appropriate treatment rather than concentrating on this area, other areas, which is specific to why they came to us to see us. They may come to see us for dry eyes, but in addition, they have keratoconus. So what are the risk factors? One of the major risk factors in children is allergic eye disease, because what that does, it would causes eye rubbing. People who have allergic eye disease, obviously they get eye itching, and eye rubbing is the problem. And you can imagine if you're trying to keep rubbing your eye all the time. And that's how I explain to patients that, for example, if you've got anything or you keep rubbing, you're deforming the cornea. And I just show them in class. I say, if you keep doing this all the time with the cornea, by rubbing it, eventually it will lose its elasticity and they become less and less. And once you do that, they will understand what I mean by not rubbing your eyes. And that's actually the most important thing, to convince the children not to rub their eyes. It's not easy, but if they understand it, they will then start to comply. And we'll also tell them they have to rub their eye I'll show them the way to rub their eye safely, basically. And the best way to rub the eye, I'll tell them just hold your hand over here, just go around bridge of the nose and you rub. And that just moves the skin over the eye without causing any pressure of the eye. So that actually give them some comfort, because a lot of them is habitual as well, habit. So even if they not have significant itching, they still want to rub. But if you show them how to get rid of that desire by rubbing safely over the bridge of the nose, because it will move the eyelid over the eye, that will significantly help. And then this second common or the second risk factor is having a first degree relative, and that will increase the risk by 15 to 67%, depending on which study you see. So if someone's father has keratoconus, or mother or brother or sister has keratoconus, you really should be thinking this patient's got very high risk of having keratoconus, and it should not be treated like any other children. You really have to follow these patients and make sure they understand they are at risk of keratoconus, especially in younger patients, basically. So it's again a very, very important factor to consider, the first degree relative. And other risk factor is systemic condition. Down syndrome, you can get the keratoconus report in patients with Down syndrome between 0.5 to 15%, which again is significantly higher than general population. Patients with Marfan syndrome and other connective tissue disorders such as Ehlers-Danlos syndrome, that increases the risk by up to 12%, basically. So in terms of the risk, this is really the main risk factors. But if you want a full detailed risk factor, this is the table of ocular condition and systemic conditions, which is associated with increased risk of keratoconus. So if they've got any of those conditions, you really should be thinking this patient is high risk and should really treat it slightly different and monitoring this patient for longer. So now we're getting to the main part, why keratoconus is different in children than adults. And I go specifically to each point why this is different and why it should be treated different. The first one is that it's a rapid progression. So in children, 88% will progress over time. So you get a child from possibly not requiring glasses to wearing fancy designer glasses, to someone starting to require extra thick glasses. They're unhappy, they can't get the vision, they like having a tunnel vision through those very, very thick glasses. And of course, the next option will be contact lens, but putting hard contact lens in children, I'm sure you all will agree, it's not an easy option, and it's going to be difficult. And even if the child is willing to wear it, they'll have to wear it for the next 60, 70, or 80 years, which again is something we really, really want to avoid, to getting to that stage of contact lens. And obviously, the next stage will be corneal transplantation, and I'll come later on why corneal transplantation as well is not a really good choice at all for children. So that's the first one, that when you see child with keratoconus, you really have to have a lot of bells going on. This child is going to become blind from corneal blindness unless we do something about it. And of course, as you know, treatment is very, very, very easy and very effective, which comes onto it. So the second reason why they are, can you change the slide, please? I don't think I can change it. No, that's okay. So the second reason is that the children normally get a late diagnosis. So in children, 30% are actually as a stage 4, which is end stage keratoconus. That's when we think the patients need corneal transplantation at the time of presentation, versus 8% in adults. So you can see there's a significant increased risk of patients presenting to us at a stage 4, which is a stage corneal transplantation. And again, my main aim is the talk is we really want to avoid that. We don't want the children to come to us as a stage 4, and we really want to do whatever possible, every one of us in whatever specialty we are, to prevent that and to decrease the risk of that at stage 4, because that will give a miserable life, basically. Of course, then we need corneal transplantation, significant time of work, then obviously significant follow-up, risk of corneal transplant failure, need for long-term steroid drugs, which then it will add into other diseases, glaucoma, cataract, and so on. So we really, really, really want to avoid that, getting to that stage 4 in children. And the one reason for that late diagnosis is the fact that a lot of children, their keratoconus tend to be very at the center of the cornea. Because it's at the center of the cornea's irregularity is not significant at the very center. There's a more uniform. So they get just a myopic shift. They become more and more short-sighted. And that's the problem. A lot of these children, they keep going to their optician, for example, high street optician, with -1, then they become -2, then they become -3. They still get 20/20 vision because this cone is central. It's not very irregular. And it keeps going until the balance changes, until that last needle breaks the camel's back, basically. And that's when suddenly they go the next visit, they see they're becoming suddenly 660 and it doesn't improve with glasses. And that's when the optician panics and will start the process of referral. But as you know, unfortunately, by then it's too late. So that's, again, it's very, very important for us to be vigilant that when we have the patients who are becoming myopic and aggressively becoming myopic, more and more myopic, even if they don't have any significant stigmatism, we really have to be thinking of keratoconus. And your Penticam is very simple, very safe, and very cheap as well. And that will tell you if they are, first of all, if they have keratoconus, if not, are they at risk of keratoconus? And you can go and sleep much comfortably, as well as the children, as well as your patient. So again, as I said, it's very, very important to bear in mind that patients becoming more and more myopic, or even if you get the patient who's a young child who's -3, -4, you really, even if it's the first time they're seeing you, you should do, and I encourage very heavily to do a Penticam. Given that we've got such a high prevalence, it makes sense in all those children to really do a Penticam and think at least about keratoconus, okay? And again, with these patients, even if we use a retinoscope, for example, they get scissoring of reflex usually, even if they got very good vision. And also if you use a ophthalmoscope, you get the old droplet actually, which we're not going to go into it today. And the next thing is, as I said, as explained earlier, is uncontrolled eye rubbing. About 8.8 to 36 patients with vernal keratoconjunctivitis will have keratoconus. And again, that's actually the third of patients, up to a third of patients. So again, if you have a patient with vernal keratoconus, any allergies, again, have a very, very high suspicion that this could be keratoconus, or this patient is a high risk of keratoconus. And you really have to stop. If they don't have it, keratoconus, fantastic. We just have to ensure that they don't rub the eye. And of course, to control eye rubbing, we really have to control itching in these patients, because they become severely aggressively itch the eyes. And actually, I mean, I'll try not to ask patients to show me how they rub their eyes, but some of them, you see the way they rub their eyes is just literally, you feel the globes going 30 kilometers into the orbit and come out. Basically, they just go, some of them with a knuckle and some of them with the knuckles at the back of their hand. So again, it's very, 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 very important that we control that. And that's actually, if we want to take one thing very important from this talk, is that children with allergic eye disease, we really need to stop them from eye rubbing, and we have to show people that eye rubbing is basically dangerous for the eye, for any patient. So the next one is this difficult diagnosis. So sorry, that should say together should be inaccurate topography. The topographies could be inaccurate, and the patient's compliance with examination and investigation may be very poor, given their young age, basically. And here we just go very, very quickly through topography, just for everyone to understand how to very easily diagnose keratoconus. So this, for example, the patient's got high astigmatism, but that's a normal cornea. So you can see basically there's no, what we call, and if you look at the map on the right upper corner and left, sorry, the right upper corner and then right lower corner, we call anterior elevation and posterior elevation. They normal, basically. And also corneal thickness is normal, essentially. So when we diagnose keratoconus, we really need to look at four things, as you can see. So there's the keratometry, there's the anterior elevation, posterior elevation, and then the next stage is the pachymetry. So this is what a keratoconus will look like, basically. The patient with a keratoconus, firstly, it will have increased keratometry. So if you look at the, I don't know, can you see my mouse at all or not on your screen? Yeah. So the keratoconus, you can see the keratometry is 48. So if you look at the top is 40.1, here's is 48. But the second thing you should look for, if they've got increased keratometry, could be increased keratometry because they've got other pathology. But with the keratoconus, then the next point you look at what we call hot on hot. So where is the highest keratometry? It will be where the cornea has the highest elevation anterior. What we call anterior elevation means cornea protruding forward anteriorly, the anterior part of the cornea. And if you look at the posterior, which is the most important part, you can see in this patient 66. Anything over 18, 15, we really start to become suspicious. So again, posterior elevation, there is significant posterior elevation. And actually the beautiful thing about Pentacam or a lot of topography machine, they will color code these. So you can see this is already red. And the fourth thing you look at is the pachymetry, which you can see here in the 422. And if you look, these are all at more or less the same location, basically. And so that gives you a definitive diagnosis of keratoconus, basically. This is literally keratoconus and cannot be anything else. But there are a lot of patients which will have increased keratometry, but anterior posterior elevation is normal. And pachymetry may still be low. For example, if they have previous laser refractive surgery and they've got irregularity because of the laser, they've got increased keratometry, then you have to distinguish, is it keratoconus or is it from laser surgery, for example. And that's we look at those four maps, we look hot on hot. And the key is really those two maps on the right-hand side, the anterior elevation, posterior elevation, and particularly the posterior elevation. If the posterior elevation is normal and everything else is abnormal, then probably I can bet it's not keratoconus. But that's very, very likely, although there is a possibility, but that's very, very unlikely because that is the first thing to show. Of course, before that, if you have biomechanical measurement like Corvus, you can check if changes biomechanically. That comes even before you see any changes on Pentacam. So the next thing is that different in children is lost to follow-up. Pediatric patients are more likely to not attend their subsequent appointment. So if you see a pediatric patient coming to you for dry eye, for squint, for whatever, and you suspect that the patient has keratoconus, you really need to get a corneal specialist to see the patient on that same visit. For example, for myself, whoever approached me to see a child, for whatever reason, I will never say no, but it doesn't matter how busy we are. So it's very, very important. Instead of saying, I'll make you an appointment in corneal clinic next week, next month, or 2 days later, just get someone to see them and make a follow-up plan and at that visit. So when I see a child with a keratoconus, actually, I almost always straight away go for cross-linking because children with keratoconus, as I say, they progress very, very rapidly. And you don't want to wait and see evidence of progression because by the time that you wait, that means their vision has decreased by another line or 2 line or 3 line, which you want to avoid. And given that the cross-linking is a relatively safe procedure, of course, with anything there is a risk, but the risk, in my opinion, of waiting for a child to progress, it will outweigh the risk of the cross-linking itself. So, as I said, when you see a patient with or suspect keratoconus, get the patient seen in corneal clinic that same day rather than rebooking the appointment. The next thing is the treatment of the surgery. This should be number 6, point number 6. The treatment not as effective. So first of all, even if they have cross-linking, up to 22% can still progress in children compared to 2 to 10% in adults. So there's higher risk that cross-linking, even if you did it, it may not work and you may need to repeat it. So normally these patients, even when we cross-link them, we see them for a long time actually, until at least they get in their 22 years. And the initial periods are very, very close follow-up, a frequent follow-up, maybe every 3 months, every 6 months, maybe then every 9 months, and then we eventually extend to yearly follow-up. But again, it's very, very important to realize the first few months to 1 to 2 years is the most crucial that they can progress again, and you may have to repeat cross-linking, and the cross-linking can be repeated quite safely, basically. The second thing is pediatric patients are less tolerant to be compliant to contact lens wear. So as I said, even if they needed contact lens wear, it's very difficult to get them to wear contact lens because they're children. But then also people usually do become intolerant to contact lens after a number of years of using it. So if we damning a child to start wearing contact lens for when they're 15, then you'll expect me to be wearing for the next 60 years or so, which again, it can be a life prison basically. So we really, really want to avoid to getting to there. And corneal transplant has a very poor prognosis and more risk of complication. Again, doing corneal transplant with child is incredibly very, very different than one in adult. In adult, keratoconus will have the highest success rate. The success rate has actually 90-95%. Corneal graft failure risk is very, very low. It actually is the lowest for any other disease apart from corneal scarring. So whereas in children is completely different, the risk of failure is very high, and the risk of irregularity is very high. So we really again want to avoid that. And they're not great candidate for alternative treatments, such as, for example, the intracorneal ring segments, ring or Intacs, basically. So that's another important factor to bear in mind, that when you see the children with keratoconus or suspected keratoconus, you really want to avoid that child to progress even a tiny little bit, because any progression or anything which gets you over a normal glasses wear is really, really, really disastrous for the child. Because these children then often they go from contact lens to corneal transplant to repeat corneal transplant to then developing glaucoma from the drops, cataracts, and then cataract surgery, and that's before they 30 or 40 years old. So you can imagine the loss the child has, both from family and family work, but also from the society-wise. Basically, they're losing the schools, they're losing work, and so on and so on. So that's why it's such an important factor, basically. And as you can agree, prevention is always better than cure. So these cases, of course, you cannot prevent keratoconus, but if you diagnose it and treat it early, it's like as good as prevention, actually, because then the treatment is relatively effective. And then the cross-linking, as I said, is usually very, very effective, and there are different protocol of cross-linking. So I'm not going to go too much into detail, but the original one was the local Dresden protocol, which was a 30 minutes of soaking cornea and 30 minutes of putting ultraviolet light. So basically, all cross-linking, for people who don't know, all cross-linking involves a very, very simple procedure. We've got the patient to lie down, only done on the topical anesthetic. Before doing cross-linking, we'll remove the epithelium, and then we put a vitamin B drop, basically, which is riboflavin. And that vitamin B will get soaked in the cornea, and then we shine an ultraviolet light, basically an ultraviolet A light on the eye. And the original protocol was 30 minutes of using ultraviolets and 30 minutes of dropping, which was very, very long. That means taking 45 to an hour to do a cross-linking. And obviously, because of that, then people started looking at other protocol to see if we can make that faster. And there are now the accelerated protocol, which takes about 15 minutes or even shorter. And accelerated protocol, when they come to it, is being shown to be as effective as Dresden protocol in quite a lot of studies, including children, actually, which we come to. And then there's another type of cross-link with transepithelial or called epi-on cross-linking, where you do remove epithelium. You just put the riboflavin straight on the epithelium and do cross-linking. But unfortunately, this one there is general consensus that there's no benefit. And in children, you should never ever try shouldn't try transepithelial epi-on cross-linking because they do progress. Basically, I had the patients who come from abroad actually had 2-time epi-on, and they was still progressing. They were offering him a 3rd epi-on cross-linking instead of just removing the epithelium and doing riboflavin. I'm not sure why, but that's actually I treated. So that I had the 3rd cross-linking, the 3rd one here with me, where we remove the epithelium. So the main challenge is if you don't remove epithelium is that the absorption, the epithelium, the riboflavin does not go through the cornea and does not get soaked into the cornea. And so there are a few different ways people try to avoid to help that. Some of them, you just make some scratches on the surface of the epithelium so that the riboflavin will soak in. There's some of them use preservatives such as back or benzalkonium, so that to loosen the junction between epithelium, so that again the riboflavin soak in. And there's another way called the entophoresis, and sometimes we do contact lens assisted. But these are all has been shown they're not as effective as the epi of cross-linking, where we remove the epithelium. And given that we're dealing with the disease which is progressive, And there's this, I always prefer to do epi on which hasn't been proven to work. Of course, we can have some discomfort, but these days we are quite good in controlling the pain and discomfort, because that's the main challenge. It can become very painful, it can become very uncomfortable, but that's for 42, 48 hours or so. So even if it was, it's still worth the worst pain that cost. So there is other modification of cross-linking with pulse cross-linking, where the ultraviolet is on and off, on and off, on and off every second or every 2 seconds, whatever you set it, there are different settings. And this basically helps increase availability of oxygen. While cross-link, while the ultraviolet is on, it will consume your oxygen, so you don't have enough oxygen. So when it's off, you have more oxygen on the cornea, so on it consumes oxygen. And by doing that, it increases the depth of demarcation line. So we say how many of the fibers get cross-linked, how deep those cross-linked fiber will go. Because of course, you will never be able to cross-link the whole cornea, you just only cross-link a third, for example, or a half. And by using pulse cross-linking, you will cross-link more tissue in the cornea. But it hasn't been shown that this to be more effective than the unpulsed or normal cross-linking. And there's topographic guided cross-linking, where basically you have a machine which specifically only cross-link where the cone is, not the whole cornea. And that improves can improve the keratometry a little bit. But again, I'm not a big fan of that. I'm much rather do the whole cross-linking across the cornea. And then later on, if we need to do anything to improve the vision, we can do. And a lot of time, I actually combine cross-linking with a bit of laser. What the laser does, it removes some of the irregularity of the cornea, and then cross-link them at the same time. And that tends to be very effective in a lot of patients. Now, up to only 2 years ago, there was no randomized controlled trial to show that cross-linking is effective in children. And because of that, a lot of governments and a lot of insurance did not fund cross-linking in children, because they said there's no randomized controlled trial, until actually Professor Larkin from Moorfield started this trial, and we were actually part of it in Liverpool as well, where we did this trial. So with 60 patients, studying over 18 months period. And in this study, actually, what's important to note that we use accelerated cross-linking, and they show that accelerated cross-linking is safe and effective. And this showed that only 7% progressing cross-linking group compared to 43% in the no treatment group. So again, you can see the accelerated cross-linking has very comparable result to what adults we expect to get in adults, which is between 2 and 10% progressing after cross-linking. So this basically puts concrete evidence that cross-linking has a role in children and should be used. Basically, you can imagine from 7% to 43%. That's a significant increase in the risk, basically. And in this study, what we used was 2 minutes of soaking every 2 minutes for 10 minutes. So every 2 minutes, you put a drop of riboflavin on the cornea for 10 minutes, and then ultraviolet at 10 milliwatt per centimeter square for another further 8 minutes, basically. So in conclusion, childhood keratoconus has a higher prevalence in this region, significantly higher prevalence in the region. There are many challenges in childhood keratoconus compared to adult, and it's important we pay attention to that. And keratoconus can progress very rapidly. And because of that, even if they see child with a keratoconus, even if we treat them, we really need to very closely monitor these children, and of course, to do rapid treatment as soon as possible to prevent the further risk of progression. And thank you very much, everyone. So we can open the floor for any question that there is sooner than the need.
To unmute yourself and ask a question, or do you want me to say it?
So if there's any question, you can unmute your microphone, and we don't get many questions at the same time. So we can take the first question if anyone has any question.
This test detect early stages of keratoconus?
Sorry, say that again. I think the question wasn't quite clear. I don't think it came up.
The Placido disc test,
Yes.
Does it detect early stages of keratoconus?
That's placebo disc is not the best option. That's really we're looking for the late stage of keratoconus. Because the early stage will look normal, so we almost never use it. But the most important thing is the anterior and posterior elevation, actually, not the changes. Because by the time you're getting changes in placebo, that's usually quite advanced. And of course, if you pay close attention, you could, but that shouldn't be the way to diagnose keratoconus.
Was when to suspect keratoconus? What are the symptoms and the signs?
So basically, whenever you get a child who having decreased vision, and particularly any child or any adult who have decreased vision and is not corrected with glasses, you should really be thinking of keratoconus, especially this region. But even a child who have decreased vision and rapidly progressing, his glasses prescription progressing, that's again, it's really keratoconus if they're proven otherwise. As I mentioned earlier, they do become more and more myopic and not even many astigmatism. And any children which has over one diopter of astigmatism, you really have to suspect keratoconus, and you really at least do one pentacam to rule out keratoconus. So those are really the main criteria. But of course, any child who have the risk factor, they've got father or mother has keratoconus, any child with got allergic eye disease, you should suspect keratoconus because the prevalence is much higher in those children.
Another question is, when using contact lenses for keratoconus, what are the options? And do they all have to be the stiff glass ones, or are there other options available?
So basically, at the earliest stages with the keratoconus, you just use glasses. But once you got to the point where you're not getting good vision with the glasses, it has to be basically hard, some sort of hard contact lenses. And of course, there are many different hard contact lenses. There's the hybrid, and there's like there are normal RGP, there's a scleral lenses, but of course that's a whole new talk basically. But soft one, it will not work. And if the soft one is working, we shouldn't put them in contact lenses. Then they will get good vision from glasses. They will get much better vision from glasses than soft contact lens. Because soft contact lens is like a clinch film. It will just mold over whatever you have. The reason hard contact lens work, so it's basically because it create it will create a dome over, and it fills with your normal tears. And so then it masks the irregularity. So if you've got the irregularity or your humps, as is stated to the patient, you've got something over it, filling it with water in between. Now you don't have a hump, basically. So it's more regular, basically.
I believe there's somebody who's unmuted themselves who want to ask a question. You can go ahead. Arshad Osmani, do you have a question?
No.
Oh, okay. Another question, Dr. Ismail, is does screen time have any effect on keratoconus?
Probably not that at least shown, but with the screen time, people can become more myopic, and that's a lot of evidence now with children and becoming more and more myopic. And any close work, basically, including reading, unfortunately, that can make people more myopic. But I don't think there's any evidence in literature to show that they will increase the risk of keratoconus at all.
What are the reasons for the high DNA in children follow-up?
So basically, there's quite multiple factors. One is it interferes with their school, and mothers may not like to take them out of the school. And a lot of them, of course, it's not like if you're an adult, you drive around yourself and you come here, whereas in the child, then there's two factors. First of all, you have to make sure the children is free. The second thing is an adult is free as well to bring them to us. And the third one is like a lot of parents may not recognize that this is so important. Was an important disease. They think it's just like they come in, they get a new pair of glasses, and that's it. So that's why it's so important to highlight why it's so important they come for cross-linking, and actually or for when they have a disease which can progress while we're dealing with amblyopia. So I think it's a combination of many factors, but there's a lot of evidence, and we can see it even here with our clinics that there's almost always higher rate of DNA in pediatric. And I think it's a multifactorial, but it's the fact that you need to be adults who off work or not with as the fact that a lot of children may have diseases, but that they may just not discuss it with their parents. They may have decreased vision, but they say it's normal, because they still got the other eye. And then they don't complain, and they don't get attention until it gets very late. So I think that's all these combinations which make it more likely that they will be in A. Whereas if it's an adult, if I know my vision is getting worse, I know something is wrong, and I try to go and seek attention. And children also, they're more tolerant to a lot of diseases. Basically, it's really for the children when it just gets to that peak that they will start becoming symptomatic significantly. They think, well, I have to discuss that with my parents or do something about it.
I was just wondering, Dr. Ismail, you mentioned that rubbing the eyes is strongly not advised to do. Do you prescribe something to help the children who have itchy eyes?
Yeah, 100%, absolutely. Because when a child rub, I specifically ask them why you are rubbing. Is it a habit, or is it because your eyes are itchy? And there's a combination. Some patients, they said, no, it's just a habit. I'm used to it. There's no itching, but I just feel like I want to rub. Those one normally, they don't benefit from drops because they don't have itching, and even if you give them drop, it will not help. But the children who they say I drop because of my eye itchy a lot, then that's completely different. Those ones, they will need drop, because if you don't stop their itching sensation, they will drop, because it's just some of this thing. The itching is that sensation of fulfillment that you get when you itch. When someone is itching, it's very difficult not to itch. And that's why for the children who have allergic eye disease or have itching, not only I prescribe, but also show them how to rub. Because by just going to the eye, close to the eye, and doing that, doing the maneuver of telling the brain I am itching, they will still get that fulfillment without actually rubbing their eye. But the short answer, yes, if they've got itching, then you have to give them some drops to control the itching. But of course, you have to find out what's causing the itching, the allergy or something else. And I find in a lot of cases, using a drop, such as, for example, Hylogel, which has Ectuin, and that has an anti-allergic effect. Actually, what it does, it will goes and bind against any allergens, and it tends to decrease the itching significantly, actually. And lubrication itself will decrease the itching because it dilutes the allergens inside the eye. So we start with that. Unless if they got severe allergic eye disease, then that's completely different. But they got a bit of allergy, a little bit of thing, I'll just give them lubrication. But something ideally which has lubrication, but also something we have with itching, like Ectuin, which has double action basically.
Oh, I have another question. What is the minimum age that you would do cross-linking, and if it can be repeated again?
So basically, for cross-linking, you can do it at whatever age. I mean, the youngest I've done has been about 6 years old, and that's I've done on topical anesthetic. So even some 6-year-olds are very, very compliant. But it can be done at any age. But it's very unlikely for us to diagnose keratoconus at earlier than 6 years, unless they have family history of abnormalities and so on. But yes, it can be done at any age. And the key is to do that, because once you diagnose and confirm keratoconus, there's only one way to stop that from progressing. The younger the child are, the more risk it progress, and the more risk it progress aggressively. So when I diagnose someone who's 15, it's different than if I diagnose someone who's 17. And it's very different if someone who's 12 years. The 12 years, almost 100% a bet that will become stage 4 within the next 6 months, 1 year, 2 years, 3 years, if we don't do cross-linking. Whereas someone who's 17 or 18, then the risk will become gradually less, but become much less once you're 2021, basically. Because with the keratoconus, the natural history is it gets worse, and that's it. It will cross-link by itself, basically. The fibers become stronger. So that's why it's very, very I've almost never, maybe one patient only, I've needed to do cross-linking over the age of 35. So once they get to 30, 35, the risk of progression is incredibly low unless they're very bad eye rubbers or they've got that they're really eye rubber or they've got other condition. Because the risk will become very, very low. So if you imagine you've got someone with the age, this is the age with top peak, and it just the risk gets lower, 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 the more the older you get. I'm not sure if I answered the question, Sona.
Have you ever done a graft on a young person, or is it unlikely?
No, I have done quite a few grafts actually in UK. And with these one, actually, as I explained before, there's a lot of challenges. Even intraoperatively, their eye is very different. There's a lot of positive pressure. Everything wants to come out the moment you want to open the eye, basically. And the risk of failure is very high as well. Risk of rejection, poor drop compliance, because a lot of these children don't want to be putting the drops for the next 1, 2, 3, 4 years or even longer. But yes, I have done it. And a lot of these patients actually, as I said, 30% of children, when they present at the stage 4, and for those patients, really graft is the only option. So it's still quite a high number.
Is there a minimum requirement for you to provide cross-linking to the patient?
So say that again, the minimum?
A minimum requirement for you to provide cross-linking to a patient?
Basically, when we do cross-linking, there's two important things. One is, the most important thing is to stabilize the keratoconus and stop it from progressing or from getting worse. And you have to be at the stage where you think the patient has some useful vision or can sustain some useful vision. But if someone is so advanced, they cannot wear contact lenses, they cannot wear glasses, vision is already so poor, then even if you stabilize it, you haven't gained anything basically because the patient is still having movement of counting finger. So the first thing before doing cross-linking, say, is there any potential for useful vision, whether it's going to be glasses, contact lenses, or whatever. And that's the most important part. But if the keratoconus already or cornea is already too thin, then you cannot do cross-linking. And normally we use 400 as a base mark. Below 400, a lot of people don't do cross-linking because then you can damage the endothelium. The ultraviolet can go deep and damage endothelium, which means then you cannot do a partial thickness corneal transplant. When you come to do transplant, you have them to do a full thickness corneal transplant, and the survival rate will be much lower in a full thickness corneal transplant. But nowadays there are new protocol, we call half-C protocol, and they basically we can do even people who are very, very thin, even 250 micron thin thickness, by using a different protocol, especially with a decreased amount of ultraviolet. So instead of having ultraviolet for 10 minutes, we have it for 1 minute or 2 minutes. So we don't have as much ultraviolet. So now there's really my strategy is if the patient has useful vision, I will cross-link. Doesn't matter how thin the cornea is, but using the modified cross-linking rather than normal cross-linking.
Would you like to ask a question? I can see there's a question from Dr. Saeed. Do you see VKC associated with keratoconus?
Say that again. Do you see?
See VKC?
VKC, vernal conjunctivitis.
Associated
That's
with
what she's severely presented as well. Between 8 to 36% can develop keratoconus. So that's all because of the eye rubbing, basically. And probably is the autoimmune and the immunity is different for those children, but eye rubbing is a key, basically. So anyone with VKC, you should really suspect keratoconus, and we should really do at least a pentagram to make sure they don't have it. And even if they don't have it, because the disease is going to go for another 5-10 years until it gets controlled. And those are the years where they can get keratoconus, even if they don't have it. But it's always nice to have a pentagram like now, and then when you're 2-3 years down the line, you have another one. You can compare them, and you can say, listen, before you didn't have it, now you started developing keratoconus. This is now what we need to do. But yeah, up to 36% can develop keratoconus, which is a huge number. So if you imagine, even in UAE, I told you the prevalence is very high. It's 2.7% in children. But they have VKC in some study, up to 36% get keratoconus. I'm not sure if I answered your question, Dr. Sayed. You can unmute your microphone.
Yeah, you answer very well. So that's why, because the VKC is common in Middle East or UAE. So that's why I think many of these children get high stigmatism and lead to keratoconus later.
Yeah, whenever I see children with a VKC, I really suspect that it's proven otherwise. And of course, when you first see a patient with vernal keratoconus, you just want to treat the disease first, control it a little bit, get the ocular surface as good as possible, and then I'll do a pentacam, so it'll be more accurate. Because if they've got very poor surface, then the scan is not very accurate. But if you have fear that they may not come, you may lose the follow-up, I will still do a pentacam during that visit, at least to give you an idea where we think. And although, like VKC, for example, the poor ocular surface, it can affect the keratometry. They could have a very irregular keratometry, but then when you look at the anterior and posterior elevation, that's the key. If they don't have keratoconus, that will not change by mere virtue of just having VKC. So I get a lot of referral patients with very poor ocular surface, very irregular astigmatism, poor keratoconus, but they don't have keratoconus, and the irregularity is because of the poor ocular surface, which will give you a lot of irregularity. And that's why it's so important when you're trying to diagnose keratoconus to have that what we call hot on hot, where that the highest point in keratometry correspond to the highest point of anterior elevation, correspond also to highest point of the posterior elevation, as well as thinnest point the thinnest point on the pachymetry. So this is really once you put this in your mind, it's very easy to diagnose keratoconus. Actually, it's almost impossible to lose or to be confused when you're wanting to diagnose keratoconus, because you've got a clear map. So if you've got someone, for example, high keratometry, high posterior elevation, which is the lower right map, that's still keratoconus, because that means they still have not got anterior elevation or thinning significantly yet, and that will come later. So I put a lot of weight on posterior elevation, because that's the first thing to change.
Another question someone's asked, what about patients with learning difficulties? What would be the best way to manage them?
So it's always a challenge with patients have learning difficulty, because first of all, it's very difficult to do a pentacam basically. But if you're suspecting keratoconus, and of course you cannot do it under general anesthesia pentacam, unfortunately, so that make it quite challenging. But the way you deal with these basically, of course, you try to do whatever best you can to get a pentacam, even if it's not the best quality. At least it give you some ideas if it can tolerate or be compliant to some degree. But other things which help you to diagnose is obviously using the retinoscopy, and they're very accurate. They're actually very sensitive. A retinoscopy, you shine it to get a scissoring reflex, even at early stages. Or if you use a ophthalmoscope, you see that oil droplet shape, even in relatively early stages. So those are the two main things. But also that's coupled with your refraction. So whether that's going to be from an autorefractor you can, or whatever system you have, refraction or retinoscopic cycloplegic refraction, that shows you high astigmatism. So then when you join them together, this patient is very high likely to have keratoconus. And if someone they've got learning difficulties such as Down syndrome, we know up to 12 to 30% can have keratoconus. Then you don't really need a pentacam, because if you don't do anything, they will progress more and more. So once I got a clue that these patients have keratoconus and they are at risk for keratoconus, then I will still do a cross-linking on the general anesthesia basically. But yes, those children are always a challenge. But with everything in life, we have to use whatever tools we have. And some patients with learning difficulties, they have good and bad days. So we speak to the carer. The carer will be the best person to highlight when is the good and bad time. Some of them are very good first in the morning. Some very good at the later in the afternoon or in the evening. So then you may want to give them an appointment when it's their peak, what we call excellent behavior. And then there are a lot of children with learning difficulties. They do have that tendency basically to be very moody first thing in the morning or last thing, and vice versa basically. So you want to coordinate with the carer to see what's the best time to bring them, that you get the most amount of examination. So again, with these patients, for example, you cannot really get pentacam at all, but all other things suggest that it is keratoconus, and they're quite young. will have very low threshold for doing cross-linking in those patients, because the risk of cross-linking, as I said, is quite low. Of course, there is risk with anything, but the risk of a child who have keratoconus progressing is over 88%. And if that progress, the progression is not like an adult. An adult, even if they progress, they can wear contact lens, they can wear, and you can do corneal transplant. It's perfect, actually. Once you're over the recovery period, once you remove the sutures, it takes some time to avoid your rehabilitation. But once they're at the end of it, usually they get fantastic results, actually. But children, that's not the case. You're really thinking of really permanent blindness, actually, even though corneal blindness should not exist. But in children, those are patients which they can have very poor vision, even with corneal transplant.
Really informative, and obviously lots of questions have been asked as well. Just a final, if there's anybody who has any other questions before we end the session. Just a reminder as well to complete the surveys that have been posted in the chat box, and certificates should be applied on TAM portal if you are a DOH licensed professional. And if not, then you can send an email to academic affairs. Oh, hello. Osama, that question has been asked already about placid disc test. Dr. Ismail, could you just go over that?
So basically, for placido disc, basically, we shouldn't really be using to diagnose keratoconus, because that's usually not very effective. It only starts showing once you get a significant change on keratometry. And by the time you get that significant change on keratometry, that's usually too late, basically. But yes, in combination, you can use it. You can still use it while doing placido on all patients, but not to diagnose it, but looking for other specific things. But in terms of diagnosis, it's much better to do, obviously, the golden standard. You have to have some sort of tomography machine which measures the anterior and posterior elevation, because that's really the key. So some patients are very thick and they still have keratoconus. Some patients, the cornea is very thin, they don't have keratoconus. And it's really that anterior posterior elevation which is the key, basically, keeping this patient has or doesn't have keratoconus. Because essentially, if you think about keratoconus, the first thing will happen is the posterior fibers of the cornea become weak, and that starts bulging forward. And that's what we call posterior elevation. And just to explain what posterior elevation is, so what the machine does, so if you've got basically a cornea which is shaped like this, and the normal cornea would be like 100% normal, would be like a perfect sphere. So what the machine does, it puts a sphere over the cornea. So if it's a normal cornea, all the numbers you see on the right-hand side, they will be 0, which means the difference between the cornea and the best fit sphere, we call it, in the sphere which perfectly fit the cornea will be perfect, then all the numbers will be 0. So there will be no plus or minus. However, when you have someone with the with keratoconus, the cornea is very almost like this, basically. So when I put it in the sphere, it would be a big gap between them. So now it measures the gap between here and the best fit sphere, and that's the distance. So what's this one and what's the best fit sphere? That's, for example, the posterior is 66 in this patient. That means there's 66 micron difference between the actual cornea and the best fit sphere. That means the cornea is bulging so much forward, basically. So that's what we call anterior and posterior elevation, essentially.
For taking the time to do this presentation for all of us. Just want to reiterate about the applying for your CME. You just do that on the TAM portal. There will be an email sent on how to do this with a guidance and step-by-step process. If you're not a DOH licensed professional, then you just send an email to academicaffairs@hplus.ae, and they will send you a certificate. So thank you, Dr.
Very much, everyone, for attending, and pleasure to be with you. Are we done, Sonal?
Yeah, we're done. Thank you.
Bye, everyone. Bye-bye.